Hello everybody, I'm Ron Waksman, interventional cardiologist from Washington Hospital Center in Washington, D.C. And I'm here surrounded by two prominent surgeons, Dr. Henke from the University of Michigan and Dr. Bulbulia from University of Oxford. Welcome, gentlemen.
Thank you.
And we are at the 49th VEITHsymposium in New York. Very exciting to see everybody coming in person. But we're going to talk a little bit about lipids, treatment for lipids. And the first question I'd like to share with you, we as interventional cardiologists and cardiologists are much more tuned to the LDL and the cholesterol parameters. Can you share with me, Dr. Henke, what is the status of vascular surgeons looking on the lipid profile of their patients?
I'd say, in the early 2000s, mid-2000s, vascular surgeons were often not prescribing statin agents or relying on their internal medicine or cardiology colleagues to do so. I think we're, as a group, much more comfortable with that now. I'd say we've kind of taken a simplistic, at least my group and others I've spoken with, is that patients at high risk, and most all our patients are at the highest risk for secondary prevention of cardiovascular morbidity and mortality, is just we make sure they're on a statin, generally a potent statin, and don't even check LDL based on perhaps an iteration of the guidelines that is a little outdated. And so that's how we handle it. We do watch for side effects, but we have not been in the habit, at least I have not been in the habit of measuring LDL, but I'm interested in learning more.
And how are we doing in Europe, in the UK, with routine checking lipid profile of your vascular patients?
Not as well as our cardiology patients, I think. I agree with Dr. Henke. Our patients are the highest risk patients for vascular disease out of the broad spectrum of vascular patients, and the most important thing we can do is initiate really good triple medical therapy, part of which includes lipid-lowering therapy. Yeah, we don't routinely check people's LDL cholesterol beforehand. I think we approached a fire and forget approach to managing high cholesterol levels, which I think is a little bit misguided. I think knowing what somebody's baseline LDL cholesterol is important. It can track compliance with medication, and also you can identify the small minority of patients with complex hypercholesterolemic pictures, which probably need something a bit more sophisticated than vascular surgeons managing their cholesterol profile.
Thank you. So that brings us to the therapy. Assuming you know that your patient have a high LDL cholesterol, already had an event, had an intervention. The guidelines said that if you're over 65, LDL should be less than 70, and now they were updated in both Europe and now in the US as well to 55. But the treatment initially is statins, and sometimes you add ezetimibe. There's a lot of questions about, and then if this doesn't work, obviously you move to PCSK9. But a big question comes, and pushback is about the side effects of statins. So maybe Dr. Bulbulia, tell us what's your thought about it. Is it really happening? Do we really have statin intolerance, and what's the magnitude of that?
I think statins are, on the whole, really well tolerated. Yeah, they're safe and they're effective, and we've got 25 years worth of really high quality trial data to support that. However, statins do in a minority of patients, 1 per 10,000 per year, cause this rare muscle problem, myopathy, which, if left untreated, can cause renal failure and death. So for that reason, it is important to counsel patients to take muscle symptoms seriously and to report these symptoms to their clinicians. A simple CK test will identify the minority of patients who develop myopathy, and you can stop statin therapy, and almost always it resolves completely. But lots of people do misattribute muscle symptoms, which are common in our patient population, to statin therapy. Recent analyses from the CTT collaboration does show that a minority of muscle symptoms are causally related to statin therapy, but actually the vast majority of muscle symptoms are nothing to do with statins. So what I do when patients report muscle symptoms to me, I check their CK to ensure they don't have a myopathy. I then suggest they try a statin holiday, stopping their statins and see whether their symptoms disappear. But then importantly, I re-challenge them. I put them back on the statin therapy. I think if the muscle symptoms disappear on cessation and reappear upon resumption of statin therapy, you've probably lost that patient to long-term compliance with statin therapy. And in those situations, you consider alternative lipid-lowering therapy, such as PCSK9 inhibition.
Do you try to switch between statins as well?
Absolutely. Sorry, I should have mentioned that. I switched from maybe a moderately effective statin to a more modern statins. So if they were on Simva, I put them onto a torvastatin or rosuvastatin at perhaps a slightly lower dose to see if that gets around the problem, because statins must be the mainstay of our therapy for lipid-lowering therapy.
Yeah, I do believe that everybody should get statins. Otherwise, they should not be eligible to get PCSK9, because PCSK9 is also has to be in adding to the statins. But let's go back to Dr. Henke and ask him, you're familiar probably with the studies in the vascular arena that did shows that PCSK9 on top of statins therapy did reduce also vascular events. So how often in the US practice, vascular surgeons or vascular medicine specialists prescribe PCSK9 to their patients?
Certainly, like was mentioned, we're pretty good with increasing the statin dose and making sure they're on the maximum maximum dose as mentioned. It is, at least in our institution, cost restricted, and so if we want to recommend a patient for PCSK9 inhibition therapy, we refer them to a special cardiology clinic. I'd say I've probably referred 3 or 4 patients who have been statin intolerant or have not gotten to levels. And kind of one of our alert is if they have repeated or aggressive atherosclerosis, particularly after endovascular or open bypass intervention. Some of those that just, for seemingly unclear reasons, have really an aggressive atherosclerotic picture.
This issue of underprescribing, especially I think in the vascular arena, is noted, at least for us as cardiologists, because we have today very clear guidelines. We see the patients who come in with coronary artery disease, and if they don't reach on maximum medical therapy, which means maximum statin therapy that they can tolerate, plus ezetimibe, we do prescribe them to PCSK9. And still we have some pushback from the providers to approve the drug, but I think this has actually been improved over time. Let's switch to one more issue. How do you feel on the pushback that if I stick to a very strict diet, I'm becoming a vegetarian, I'm not eating anything that is rich cholesterol, I'll be able to manage my own cholesterol? How much do you hear it from your patients, and how do you handle that, Dr. Bulbulia?
Patients are bad at sticking at good diets. And even the best diet may lower your LDL cholesterol by around 10%. And we know all the randomized data show that the magnitude of reductions you get in cardiovascular events is directly related to the reductions you achieve in LDL cholesterol. So even a good diet won't really do very much for reducing the burden of disease our patients suffer. That's not to say that you shouldn't have a good diet, but the benefits of statin therapy are much greater than diet and additive to it as well. Just to mention as well, the new kid on the block, inclisiran, which is a new approach of stopping PCSK9 production at the liver, and it's got an advantage over PCSK9 inhibition with monoclonal antibody therapy in that it can be just given 6 monthly. So it raises the potential for a vaccination for cholesterol, which is quite intriguing.
Sure, no, I agree. It's very intriguing because it's becoming like almost vaccination. It's an mRNA. So it's very minus the vaccine that we get for COVID. And if you have to do it 2 times a year, it's not a big burden. Very side effects, although it's not as potent as the monoclonal antibodies. You drop it to the 40 and not to the 20. So I'm going to ask you, Dr. Henke, I mean, are you comfortable with having your patients on an LDL of 20, or are you concerned that too low of an LDL is going to be some sort of concerns?
Well, 20 is pretty low, and I'm not a lipidologist. It made me a little bit nervous, I guess, just from maybe some of the wives' tales about it. But I think definitely getting the 40s and 50s seems to now be state of the art. And I think, cardiology is at the forefront of this, but I think, continuing to educate vascular surgeons, because again, it's come a long way, but even as reflected from the BEST CLI trial within confines of a really well-controlled trial, I think statin use was only 60 to 70%. So there was a delta there to increase that, and that will be hopefully one of the messages.
I think patient awareness and physician awareness is very important. That's what we're trying to do at the VEITH meeting. I would add one more important maybe marker that we need to look is Lp(a), because this is a marker for atherogenicity. And we do know that every 5 patients have a high level of Lp(a). Until now, we didn't pay attention to that because there was not much to do with that. But now there are some drugs that also coming with an mRNA that showed very nicely, can you drop dramatically the Lp(a). Whether this is going to impact clinical outcome, we still need to have a clinical outcome study. But until then, I think it's upon us to make sure that there will be awareness, especially in the vascular arena, on reduction of the LDL, being aware to what is your lipids profile. I think that should be mandatory for every patient that come to the vascular clinic and undergoing any endovascular and vascular intervention. So with that, I'd like to close the session, and I'd like to thank both Dr. Henke and Dr. Bulbulia for contributing a lot of important points to giving more awareness to our audience about lipid management.